asked the permission from Dr. Cooper that I can use the Chinese Mandarin to introduce him, because he has so many great things now. So I think that most of the audience came from Taiwan, and we use the Chinese Mandarin, and that will be better for the audience. 这样子的话，我能够比较完整的介绍 Dr. Cooper。我相信很多的同仁都曾经听到 Dr. Cooper 的演讲，他已经来我们台湾很多次了。那就像我们的介绍一样，这个资料介绍。那么在这个肾脏的营养学的方面 ，Dr. Cooper 是一个创始者，所以我们尊称他为肾脏营养学之父，也不过奖哈。那其实 Dr. Cooper 他现在是这个美国UCLA 的这个UCLA Harvard 这个 Hospital 的这个肾脏科主任长达25年。那他现在是美国洛杉矶分校大卫格芬医学院的医学及公共卫生学院及美国 UCLA 非丁公卫学院的教授，那有很多的 title。那他在肾脏营养方面的这个贡献呢，我们大概都不用质疑了哈。那在过去的话，发表过接近500篇的研究报告，那么在各个肾脏营养的领域里面都有很好的成果。那我们所念的 Nutrition Management Renal Disease 也是他所主编哈。那么他也得到各种的这个奖项哈。那也曾经当过美国肾脏基金会的主席，美国静脉及肠道营养学会的主席哈，那国际肾脏营养及代谢营养医学会的主席等等哈。那我要特别提这一件事情哈 ，Dr. Cooper 同时也非常的热情致力于在那个国际肾脏基金会联盟。那么值得一提的是，台湾的像林一峰副院长他的那个台湾肾脏防治基金会吧。那么在大概4、5年前哈 ，Dr. Cooper 跟我一次聊天说，Dr. Huang， 你们有没有肾脏基金？我说我们没有，有一个私人的哈。那他说为什么不参加这个IFKF International Federation of Kidney Foundation？ 那回来以后，不用回来，我在日本那时候就赶快跟林一峰副院长联络，因为我觉得只有他的那个学会大概够格去参加，而且一个国家只能一个哈，所以谁捷足先登就可以。那这个过程里面 ，Dr. Cooper 给我们很多的帮忙哈。那我记得大概1年多以前，我们终于也加入这个 International Federation of Kidney Foundation， 所以我们应该再次的谢谢他。I would like to thank Dr. Cooper for your kind help and to suggest Taiwan to join the International Federation of Kidney Foundation. We have done that. So thank you very much. Thank you. So 今天Dr. Cooper 要跟我们谈的主题是心肾病患者的蛋白管理的大哉问的哈。那因为大家知道这些病人他随着病程的变化，蛋白的摄取量会高高低低。那刚刚杨副院长提到这个肠道的这个nutrition等等，我特别注意他提到几个观念。第一个就是要multidisciplinary 的 team， 而且这 team leader 要相当的 enthusiastic， 很热情哈。我想在肾脏的营养学 ，Dr. Cooper 就是像这样子的一个领导者哈，那带领的整个世界上的肾脏营养学的发展哈。那 Let's welcome Dr. Cooper.
I'm going to cover a lot of ground here, if I may. And the title was actually insisted upon by Surrender Wong, which is what is optimal dietary protein therapy in the course of diabetes of a patient who starts with prediabetes and obesity and ends up with diabetes and then chronic progressive kidney failure. And this is what I will try to cover. First, these are just my potential conflicts of interest. Now, what do we mean by a high-protein diet for pre-diabetic patients? Normally, the percentage of protein, of calories or energy which comes from protein is around roughly 15 to 20%. And with high-protein diets, it's been recommended that it be a little higher, anywhere from 20 to 35%, which is quite high. about 45 to 60% from carbohydrates, 20 to 35% from fat. This is a percentage of calorie intake. This translates to about 1.2 to, that should be 2.4, not 12.4, 1.2 to 2.4 gram protein per kilogram per day. It's rather high in dietary fiber, 20 to 35 grams per day, contains a moderate amount of polyunsaturated fatty acids, and it's restricted in saturated and trans-saturated fatty acids. Now, there are a number of benefits that I reported to the use of these high-protein diets for diabetics, and these, this was really introduced, this concept, in the around 2000, about the beginning of this century. It's commonly recommended for pre-diabetics and for type 2 diabetes mellitus. Why not type 1? Because it affects the secretion and sensitivity to insulin, but also the secretion of insulin. And of course, type 1 diabetics produce little or no insulin. Not only that, it's related to reducing insulin resistance, which we know is a major factor in type 2 diabetes, who are either elderly or obese or both. It's reported a lower blood glucose response to meals, decreases HbA1c levels, lowers serum lipids, increases serum HDL cholesterol, and may promote early satiety, thereby decreasing the total amount of food intake of the patient. In some patients, high-protein diets facilitate weight loss, and in fact, in the United States, there was a series of studies looking at high-protein diets in non-diabetic obese people as a way to reduce protein into body fat, and it works, actually. One of the most famous of these diets was called the Atkins diet. You may have heard of that. And in fact, the way it works is probably very simple. When you eat a high-protein diet, you reduce your calorie intake. And it's been shown that the average reduction in daily calorie intake in somebody eating a high-protein diet is around 400 to 500, probably a little closer to 400 kilocalorie per day reduction in nutrient intake. And if you've ever tried to eat a high-protein diet, you'll know that it works. You lose your appetite, at least part of your appetite. And the converse of that is something to keep in mind, is that sugar actually stimulates the appetite. People who work with weight loss patients know this, that however it works, whether it's just an effect on the taste or whether it's a much more complex metabolic response, I suspect it's the latter, I'm not sure. But this is probably one of the main ways in which these high-protein diets do seem to both cause weight loss and reduce the risk of developing or the severity of diabetes. It may also preserve lean body protein mass during weight reduction. And in fact, there are a lot of data that the diabetic patient has increased gluconeogenesis, that's increased production of or degradation of amino acids and production of glucose from the amino acids, from certain of the amino acids. And in fact, there's evidence that diabetes long-standing does produce muscle protein wasting. Again, an argument for at least an adequate, if not a high protein intake. Now, what's the mechanism by which high protein diets work? Well, as I said, in part it may be due to the fact that it induces early satiety, but it's much more complex than that. It includes delayed gastric emptying with slower release of sugars into the circulation. Lower carbohydrate intake, simply because for any level of calorie intake, there's more protein that's ingested. And hence reduced calorie intake also produces, as I mentioned, weight loss. Now, I've included a study published last year that I think typifies many of the complex metabolic changes that occur with a high-protein diet. This was a study in which 8 patients with early type 2 diabetes mellitus were each studied twice at 2 to 4 week intervals. And once they drank 500 cc of water, the other time they were studied, they ate a meal containing 23 grams of protein, 17 grams of fat, and 2 grams of carbohydrates. The patients then drank 30 milliliters of water. The order in which each of these 2 meals, the water or the protein, fat, carbohydrate meal, were fed was determined randomly. Now listen, 30 minutes after each glucose meal, 30 minutes after this preliminary meal, the patients then drank 147 milliliters of water containing 50% glucose with 1.5 grams of a non-radioactive but isotopically labeled glucose. So they all ingested roughly 73 grams of glucose after either drinking water or having this meal. Now, this slide shows some of the characteristics of these individuals. They averaged 63 years of age. They were both men and women in the study. Their body mass index was slightly increased, was slightly into the obese range, 31 kilogram per meter squared. And their HbA1c was elevated, but they really didn't quite classify, or they classified as being actually very mild diabetes. Now this slide shows the response of the glucose, which you can, I'm sorry, what did I do here? Excuse me. Here. The response of the glucose, which, as you see, rose higher in the, I'm having trouble reading this, it's too far away. But this is the, yeah, in a moment I'm going to be standing right in front of you. So it's okay, I'm sorry. But normally you have the screen is right on the podium. But this is, I guess, exogenous glucose. Excuse me, I'm coming down here. Sorry, in a moment I'll be sitting in the middle of the audience. But anyway, this slide shows the production, the glucose levels, and you can see that the glucose from what was ingested, what was ate, was much higher in the people who were pre-fed water as opposed to protein. Now think about this. If you eat a protein meal for several hours afterwards, it actually alters your ability to handle sugar. It's fascinating, isn't that? And this is for a number of reasons, which we'll come to. This shows the production, or we're always producing glucose, not just actually in the liver, but that's the major source of glucose. But what's the other source of glucose in normal people? The kidney. The kidney actually is a major source and produces, in a person who's fasting, I'm digressing, but it's fascinating to be a kidney doctor. The glucose actually produces about, in a person who's fasting, about 25% of the total glucose that's produced comes from the kidney. And this is in part due to the fact that when you fast, you break down amino acids and protein, you're developing an acid load. Acidity causes the kidneys to increase ammonium excretion. And what does the ammonium come from? It comes from the degradation of amino acids. And in the process of forming ammonia, you're also forming glucose from the carbon skeleton of many of the amino acids, particularly glutamine. So the kidney is a fascinating organ. Anyway, let's look at some of the other slides. This slide shows the first here in the center. Excuse me, I'm pointing it. I think I just lost. Oh, here it is. In the center, this is glucose-like peptide, and over here we have glucagon-like peptide 1, and you can see that that these actually rise higher. The solid line is after the protein meal. And the glucagon levels also rise. So protein actually, it's really the amino acids in protein actually stimulates the production of a number of hormones which act to regulate the insulin, the glucose levels, and they increase the secretion of insulin, and also affect its sensitivity. So let me summarize what this study shows is that decreased glucose absorption caused by delayed gastric emptying due to food in the stomach, which is probably at least largely, if not entirely, due to increased glucagon-like peptide 1. It also increases beta cell function in the pancreas, which is caused by a more active cephalix phase of insulin secretion, and also increased levels of glucagon-like peptide 1 and glucose-dependent insulinotropic polypeptide. It stimulates beta cell insulin secretion due to intestinal absorption of amino acids and possibly lipids. The result of all this is increased insulin secretion when the blood sugar is at the fasting level, and reduced insulin clearance from blood. And I showed you those earlier curves, which in fact confirm this. So this is a study indicating the acute effects of insulin, of a protein meal, and actually tending to cause better glucose control and better glucose tolerance. But these are short-term studies, acute studies that are occurring over a matter of hours or a day or two or three. What's the long-term effect? Well, here it's not quite so clear. These are studies, or a summation of studies of high-protein diets fed for 1 week to 6 months, and this is 6 months or longer. And you can see that, and the data are broken down to whether patients are healthy, whether they're obese, whether they have insulin resistance, type 2 diabetes, or whether they have any combination of this. And what the data show is there's actually a wide variety of responses. I'm particularly concerned not with the immediate effects, but whether the long-term effects of a high-protein diet are beneficial or not to the patient. And so I would urge you to concentrate on the data collected for more than 6 months. And there are some data indicating increased risk of type 2 diabetes, and other data, one study indicating that the risk of type 2 diabetes decreases. And we need to remember that as has been said, anything can happen in medicine. And you may find an acute effect, which looks wonderful, but until the long-term effects on key outcome, on morbidity, mortality, quality of life are tested, you don't really know whether the treatment is good or not. And I would suggest that these studies raise serious questions as to whether these high-protein diets are beneficial. Now, this is a complicated slide, and this is very hypothetical, but the purpose of this slide is to, these authors are focusing on something called the target of rapamycin, which is a very important signal transduction protein inside the cell, mTOR, and it shows that a number of factors can affect this. Branched chain amino acids levels affect this. We'll learn more about this later today with what I'm sure will be an excellent talk on that. Glucose affects this, and if there's an arrow, that means that it's increased. It has a direct effect. If there's a little bar here at the end, it indicates that it's an inhibitory effect. And you can see that a number of these factors affect mTOR, and they lead to many different changes, including fatty acid oxidation, protein synthesis, but they also lead to increased or reduced glucose sensitivity to insulin results. And these authors are arguing that long-term protein high protein intake, in fact, may inhibit this critical central protein inside the cell cytoplasm that regulates not just lipid and protein synthesis and metabolism, but also glucose metabolism. Now, let's look a little more with regard to the potential effects of high protein diets on the kidney. And there are data that high protein diets, very good data, increase proteinuria in people who have any degree of kidney disease. That high protein diets increase renal blood flow, glomerular filtration rate, and the pressure inside the glomerular capillary, which can lead to what has been called intraglomerular hypertension, which in fact has been considered to be an important factor leading to progressive kidney failure. High protein diets in general engender many potentially adverse metabolic and biochemical changes in the kidney and in the systemic circulation, and that it might enhance the rate of progression of kidney failure. Let's look at these in a little more. Well, let me continue, then we'll come back. It also may, we know that acid is one of the factors that result from protein diets. That the rule of thumb is that each of us produces 1 milliequivalent of acid per day for every gram of protein that we eat. Rough rule of thumb, crude number. The more protein, the more acid production. And that leads to acid urine, and this may promote the progression of chronic kidney disease in people with kidney failure. I'm going to show you data on all of these in just a moment. It promotes osteoporosis, probably related again to acidemia, and also to the fact that there are certain amino acids, cysteine, methionine, taurine, that in fact are metabolized to sulfate, which is excreted in the urine, commonly with calcium as the cation, and this may be one of the reasons why, and this has been shown, high protein diets are associated with an increased risk of osteoporosis. A lot of data on this. Our nutrition expert is nodding. He said, "Thank you very much." And diet also induced anorexia may be undesirable in chronic kidney disease patients who, as I've mentioned, show evidence of protein wasting, not so much energy unless they're type 1 diabetics, but certainly protein wasting. And if people who have advanced kidney disease, there are a lot of metabolites of protein, which in fact are uremic toxins. Well, let's look at each of these quickly, but in a little more detail. This is just one slide showing. It's in rats, but you know, we humans are not that different from rats. And it shows that in comparison to a low protein diet, a high protein diet is associated with far more albumin excretion in rats who have a chronic type of kidney disease. Increased protein excretion with high protein diets. I am sorry I had a slide showing the same thing in humans, and somehow this morning I couldn't find it. What about the adverse effects of proteinuria? We know that with increased amount of protein which is filtered by the glomerulus, and that gets into the tubular fluid, all types of issues can occur. There's increased amount of this protein is actually reabsorbed and deposits in what's called the mesangium of the kidney. Not only that, but proteins, particularly albumin, are carriers for many bioactive compounds. And one of the functions of albumin is to carry less soluble compounds. And when this albumin is filtered, it carries with it bioactive compounds that get exposed to the renal parenchyma. It's been argued this is one of the reasons why proteinuria with any kidney disease, the presence of proteinuria is associated with increased rate of loss of kidney function, a more rapid development of kidney damage, and those patients who have high levels of proteinuria, in fact, it's been shown, have more rapid progression of kidney damage and more rapid loss of kidney function. Again, this is high protein diets we're talking about, but in people or animals who have kidney disease. What about increasing renal blood flow glomerular filtration and intraglomerular pressure. There's a lot of data on this. And incidentally, I'm summarizing. There are dozens of papers on these subjects. But this shows you data from normal people. I'm sorry, these are dogs again. Normal dogs that were eating a control meal, not particularly high in 10 grams of protein per kilogram body weight, showing there is a rise in renal blood flow, glomerular filtration rate, no change in arterial plasma glucagon. Glucagon stimulates blood flow by the kidney and glomerular filtration. But look what happens when they eat a much higher amount of protein, in this case actually from meat. And you see, look at the rise in renal blood flow, the increase in glomerular filtration rate, and the rise in plasma glucagon. Now let's understand that one of the changes that happens in the kidney of a patient who has long-standing diabetes, not in every patient, but in somewhere around 38 to 45% of long-standing diabetics, is they hyperfilter already. They have increased renal blood flow, GFR. You give a high-protein diet, and it's been shown. This goes up even more. Now, I mentioned that it engenders many potentially adverse metabolic and biochemical changes in the kidney and systemic circulation. This is a study showing, this study, I'm sorry, is a little out of order, but it shows the increase in urine albumin and the glomerular protein when rats are fed a high protein as opposed to a usual protein diet. But look at this. Look at the production in the glomerulus of various eicosanoids, prostaglandin E2, PGF2 alpha, thromboxane, and you can see that some of these, including PGE2, increases significantly, as does thromboxane. Now, these are vasodilators in the kidney, and they also have other, particularly thromboxane E2, have other histologically damaging effects inside the kidney. And let's again look now at the effect on progression of renal failure. Do high-protein diets cause more rapid progression of renal failure? Well, this is a very controversial question. But let's look at the data from diabetics. It's actually not so controversial. The data are much more suggestive of that it affects. These are the meta-analysis of a number of different studies, again, exclusively in people with diabetic renal disease. And you can see that there's a clear increase in these are low-protein diets, in reducing the time to the start of dialysis therapy. Now, you might start dialysis therapy because you have less uremic toxicity. It's not necessarily related to the rate of progression. But let's look at the data from Kasiski. Now, Kasiski published a meta-analysis many years ago, 20 years ago, in which he indicated that in the general population, non-diabetic, of people with kidney disease, that low-protein diets do have a small but definite effect in slowing progression. But the rate is so small, he argues it's not worth putting patients on a low-protein diet. The reduction in the progression was 0.53 milliliters per minute per year. Okay, got that? A half a cc per milliliter, a half a cc of GFR per minute is saved per year by putting them on low-protein diets. A very small effect. Although we have to remember that many of the patients in these meta-analysis did not adhere closely to low-protein diets. This was all the people, not just those who adhered to the diet. Nonetheless, the effect is small, okay? Now, Kasiski went back and looked only at those patients who had diabetes mellitus, and he found, in fact, a significant reduction in the rate of progression of renal failure with low-protein diets. So the same man who reported that the effect of protein restriction on progression is inconsequential, is of no value or almost no clinical value, almost none, in the general population, is reporting that with diabetes, in fact, it does have a substantial effect. Now, as you know, people talk about 0.8 gram protein per kilogram per day as the required diet. I don't accept that at all. In fact, almost nobody who works in dietary management of kidney disease accepts this. Where does this number come from? It comes from one study, the MDRD study. And let me show you how, the word in English, how tenuous, how inconclusive the data are. This is a slide from which the 0.8 gram per kilogram per day recommendation comes, right? First, it's a post hoc analysis. It's after the fact. And what they did, a friend of mine, Andy Levy, what he did was he looked at the actual intake of the patients, because we collected urine, you know, so we were able to estimate pretty closely what the patients were eating. And he looked at the actual intake of the patients. This is the actual intake here. This is the same, but this is without some of the patients were getting ketoacids. This is without the supplement. So this is really, see, that's from food only. And this is food and the ketoacid supplements. And he showed that as you decrease the protein intake from this is about 0.85 gram per kilogram per day, down to 0.625. This would be like a 40-gram protein diet. That, in fact, the rate of loss of GFR per year became less and less. You lost less GFR for those patients who were actually eating about 0.6 or 0.8 or lower. But look at the data. Look, these are the mean values for each of the intakes, the patients. And look at the data. Is this a very tight line? What do you think the 95% confidence limits are? They go from here to here. I would argue that the amount of protein that people should eat, they rounded off to 0.8. This is 0.75, which is right here. I would argue that very likely giving 0.6 gram per kilogram per day or even less may actually be associated with a slower loss of kidney function. Am I clear in what I'm saying? These are, I think, but what they did was they rounded 0.775 to 0.8. So, okay, so this is not really different from this, although it is different. It's a little lower, not much. But look at this value. Look how much lower the rate of progression is here. This is the basis of the 0.8 gram per kilogram protein diet recommendation. And this is the reason why many people who've studied this say, look, Andy was on the steering committee, Andy Levy, and they felt they had to come up with some recommendation. So that's the number they picked. I think it's a very, very, very loose number. Now, please remember that all of these studies on the effect of protein restriction on progression have compared the effects of a low protein diet as compared to normal diets or to other diets that are low in protein but not quite as low, right? All of the meta-analysis show at least a trend for low protein diets to retard progression. Would this not likely suggest that exceptionally high protein diets, which have never been studied on progression, are likely to promote progression more rapidly? I mean, we're giving a diet that if somebody has kidney disease, nobody's ever tested whether the progression is more likely. And everybody shows that comparing a 0.8 or 1 gram per kilogram to a much lower protein intake slows, at least there's a trend. Whether you think it's important clinically or not, there's a trend toward lower progression. So what do you think would happen if you bump the protein intake way higher? Wouldn't that suggest at least a possibility that these patients are going to lose kidney function more rapidly? Moreover, there are data, very clear published data, that diabetics without clinical evidence of kidney disease, namely they have normal serum creatinine and no increase in total protein excretion in the urine or albuminuria, no increase at all, can have histological evidence of kidney biopsy for early diabetic kidney disease. So what I'm trying to say is, you know, it's been argued, well, at least try the high-protein diets for people who don't have kidney disease. Well, what diabetics don't have kidney disease? How are you going to know that? Are you going to biopsy all your diabetic patients? And if you don't, again, I'm not arguing that it is proven that high-protein diets, not normal, but high-protein diets, are toxic to the kidney. I'm not arguing it's proven, but I'm turning it around and saying there's no evidence that it doesn't cause a harmful effect on the kidney. And if you say, well, what about for people without kidney disease? My argument is, who are these people? How do you know they don't have kidney disease? Are you going to know this by looking at the serum creatinine? By examining the urine? That doesn't give you the answer. Now, again, I come back to what Hippocrates said, which is first do no harm. So I frankly am afraid to give high-protein diets, not because I know it's bad, but because I don't know that it's safe. Okay? Now, moving along here, this is just a study. This was a study carried out in 1,300 Norwegian people aged 50 to 62 who did not have diabetes mellitus, but they had prediabetes diagnosed by fasting blood sugar of 110 to 125 and an HbA1c of 6 to 6.4%. And this is the diagnosis as suggested by the American Diabetes Association. Median follow-up was 5.6 years. And this slide shows before and afterwards. It shows the urine albumin excretion. This is the change in GFR. The GFR in the same people before and 5.6 years later. And the albumin excretion. And you can see that it's moving toward lower GFR and toward increased proteinuria. And these are not diabetics, they're pre-diabetic patients. So again, I would argue that for obese people who at least have the diagnosis of prediabetes or of the metabolic syndrome, I again would be very reluctant to use these high-protein diets. Now, there's also an increased acid load from protein diets. It is associated with increased body protein degradation, body protein depletion, increased morbidity, increased frequency of hospitalization, more rapid progression of kidney failure. Let's look at this a little more closer. This is a study that we published several years ago where we studied 8 automated peritoneal dialysis patients, including 3 diabetics, who we studied in a research ward for at least 42 days each. Patients were not allowed to leave the ward without one of my technicians walking step by step right with the patient. They were studied in a randomized crossover design with, first of all, they were fed a constant protein diet. The peritoneal dialysis regimen was absolutely constant throughout the entire 42 days of study. They were then in a randomized crossover study with half the time where the arterial pH was dropped to 7.35 to 7.37. The other half the time, the arterial pH was raised to 7.43, 7.45. Now let's think of this, right? If you were to ask a typical healthcare worker, what is the normal arterial blood pH? They would say usually 7.35 or 7.36 or 7.45. Am I essentially correct in that? Isn't that the range of normal? I don't think it is, incidentally, but that's what's reported. Who comes up with what's right? A pathologist does this, a clinical pathologist. And I would argue if there's one doctor who can't tell a lie from a dead patient, it's a pathologist, and yet they're telling it what these numbers mean. So let me show you what we found. There was one outlier, but of the other 7 patients, look at the nitrogen balance on the lower arterial blood pH and the higher arterial blood pH. Again, these are, supposedly with high normal arterial blood pH, low normal blood pH. And this shows the SU and serum urea nitrogen was higher with the acid pH. Remember, these are peritoneal dialysis patients. Body weight a little lower, and nitrogen balance significantly, well, that's in the entire group of people. P was 0.06. If you exclude the outlier, the P was 0.003 values with the lower pH being associated with less positive protein balance and the higher arterial pH. So I would argue that even mild degrees of acidemia may be harmful. They may promote protein wasting. But let's look at this from another point. Let's look at this with regard to the kidney. And there are several studies. Now I'm going to show very briefly 2 studies which are randomized prospective controlled trials where people with chronic kidney disease, not on dialysis, here the estimated GFR in these patients was 32 in one group, and let's see, what was the other group here? 33. And these people were random, that was the estimated GFR, that's right, determined from the serum creatinine. And they were randomized to receive either no sodium citrate or the alkalinizing agent sodium citrate, and they were followed for up to 30 months. And look what happened. In all of them, of course, there was loss of GFR, correct? You'd expect that. They have chronic kidney disease. But if you compare the citrate group to the no citrate group, you see that the loss was significantly greater. Look at these p-values, significantly greater in the people who did not receive the alkalinizing agent. And this slide shows the urinary endothelin, which is this is a compound produced in the kidney which causes fibrosis. It's a fibrosing compound, endothelin. And look, at 30 months, the endothelin levels were significantly lower in the patients who received the sodium citrate, the alkalinizing agent, as compared to those who did not. And this now is another study in which patients were given either sodium bicarbonate, no sodium bicarbonate. Their blood bicarbonate, serum bicarbonate, was 20 millimoles per liter at the start of the study. At the end of the study, those who received bicarbonate, the sodium citrate averaged 24 milliequivalents. You know, that's normal. We're not talking about making people have alkalemia. And look at what happened over the next 24 months in terms of not needing dialysis. About 5 or 10% of the people who got the sodium bicarbonate needed dialysis at the end of the 2-year period. But those who did not receive sodium citrate, about 35% of the patients required dialysis. So again, another randomized prospective controlled trial. Now this study I put in for just a different reason. It talks about it's just an observational study looking at, in diabetic patients, the number of people who are likely to develop proteinuria. And it turns out that it varies according to the racial ethnic background of the patient. This is a paper published 3 years ago. And you can see, I put this in actually because we have here, these are all Americans incidentally, but these are the Americans of Chinese descent, Americans of Filipino descent. And these are the one with proteinuria and diabetes. And again, they have a slightly greater likelihood of having proteinuria. And these are, again, the Chinese here, Filipinos here, less likely to be non-proteinuric diabetics. So, again, these are all Americans, but those of Chinese descent seem to have a slightly, in this study, and there were about 1,600 Chinese patients in this study, they seem to have, for whatever reason, a slightly greater likelihood of developing proteinuria. So these people might be particularly at risk. I don't know, but it certainly raises a question as to whether they're at particular risk for developing worse kidney disease with high protein diets. And this shows the data right here. Again, it shows it tabularly, and you can see, again, these are the Chinese Americans here. And again, you can see that they have an increased likelihood of, up here, increased likelihood of developing proteinuria, and it shows that that's not due to the fact that they have less angiotensin receptor blockers or inhibitors. Now, I mentioned osteoporosis. High protein diets are associated in the general population with increased risk of osteoporosis. High protein diets, as I mentioned, increase calciuria, probably because of the acid load, maybe because of increased sulfate production from the 3 sulfur-containing amino acids. The increased sulfate synthesis from these sulfur amino acids found in protein or meat, as I mentioned, the cysteine, methionine, taurine, do promote increased urine calcium excretion. So let me summarize where I'm going with all this, and that is that high protein diets, possibly with a low glycemic index, may offer many benefits to pre-diabetic patients and to patients with type 2 adult onset diabetes. These benefits include better plasma glucose control, a healthier plasma lipid pattern, possibly greater weight loss. However, high protein diets may promote more rapid progression of diabetic kidney disease and cause other adverse metabolic effects, including acidemia, induced protein wasting, osteoporosis. We also don't know whether long-term, whether these high protein diets may actually increase resistance to insulin, as I mentioned. Concern for these possible adverse effects is heightened because early diabetic kidney disease may be present without proteinuria, other abnormalities in the urinalysis, or elevated serum creatinine values. Hence, if high protein diets are contraindicated when diabetic kidney disease is present, we may not know when this complication occurs. Moreover, previous studies that suggest that low protein diets compared to normal protein diets may slow progression of diabetic kidney disease. No study has examined whether high protein diets may have greater adverse effects on progression of kidney disease. These considerations suggest that high protein diets be used with caution, if at all, in pre-diabetic and type 2 diabetic patients until the results of more research are available. And I would like to thank you very much for your attention.